on the level of resorption, and that's why time is an important factor, and how quickly do we determine these is an important factor. Then you are going to have a different prognosis. The studies that Dr. Heather did in this in his evaluation, he found that in class 1 and 2 cases, they managed to get about 100% success rate in terms of addressing these resorptive defects. In class 3, it dropped down to 78%, and in class 4, it was as low as 12% success rate. Now, the key here then is to find out how as quickly as possible that there is a resorptive process. And I personally myself have determined also that there is another second factor that's super important too, and that's
Dr. Nasseh, it's been a long time and I'm super grateful you're here to answer a few questions. Actually, one question, but how have you been?
I've been doing well. Thanks so much, Ash. I'm been super busy, and I've also been really happy to see that you've been busy as well, creating content, and doing a great job with all the stuff that you do. So, that's good. And guess what? We're wearing matching shirts today. So great minds think alike.
So one of the cases I had messaged you earlier about a month ago, and I'm grateful for your answer, and it had to do with external resorption. And I'm not sure, maybe you're seeing more of it. I'm not sure if it's more prevalent or we're just looking for more. But you had a really great answer, because not always do we need to treat it, and not always, because there was a new article in the Journal of Endodontics that talked about kind of waiting.
So, I mean, to go back to what you were saying about whether there has been an increase in the incidence, external root resorption, or more specifically, invasive cervical root resorption and things of that sort. I personally, it's been my personal anecdotal experience that there has been a rise. Now, that could be because, I'm getting more referrals of it, perhaps because there are now, with the rise of CBCTs and a better understanding of these entities, people are diagnosing them more readily. But I personally think because of the rise of adult orthodontics, which includes, with the, whether it's your Invisalign or all of the newer options that more and more people are having orthodontic treatment as adults. And we know that in about 1% or sometimes even less than 1% of cases with orthodontic treatment, you end up having external cervical root resorption, not just pressure resorption from movement, but in addition to that, cervical root resorption and things of that sort that are far more pathological than just pressure resorption from movement. I think even if the incidence has not increased, the fact that there is more prevalence of orthodontics, overall prevalence of external cervical root resorption must be higher, and also to add to that diagnostics and so on, and that we're going to see a lot more. So I think it's very important for your audience and all of endodontists and general dentists out there to really not only be familiar with these things, not only understand the etiology and the causative agents, but also be able to manage these kinds of cases in a way where patients' long-term outcomes are always considered as the main indicator.
I've tried to treat cases before, and ultimately it seems like, depending on the classification, it ends up possibly an extraction. And unfortunately, and I think you're probably going to, I'm assuming you'll say, depending on the classification, it's time to treat, or it's time to plan for the future before the case becomes worse off.
Right. So let me do a quick review of, first of all, what is the etiology, what causes these external cervical root resorptions, then quickly talk about some of the classifications, and then talk a little bit about some of the main factors involved in trying to make a decision on triage. Does that make sense? Is that okay?
Oh my gosh, that's amazing.
So let's quickly talk about the etiology. Now, first and foremost, we talked about the correlation that exists with cases like orthodontics, with trauma. There are some idiopathic reasons and so on, but almost always the main reason is where resorption occurs is because the protective layer that is kind of like like a Star Wars equivalent of a shield around your spaceship, we have that same equivalent on our roots. And that's preventing our regular osteoclasts that are typically turning over bone in the process of bone coupling that occurs constantly throughout our body, so that every 10 years you get a brand new skeleton without really realizing this. That this does not affect your teeth, because your teeth you're with, and that's essentially, for your adult set of teeth, that's going to be it. So those surfaces, those calcified surfaces, have to be protected. And from an evolutionary perspective, the way these kind of monocyte-driven cells that are osteoclasts, where they end up attacking the teeth, they end up being odontoclasts, identify that they should not be attacking the root, is the current theory is because of the demineralized layer of cementum, or underneath that dentin, the demineralized layer of dentin on the inside of the pulp. That outer layer is always demineralized, right? That's predentin or pre-cementum. So those cells, these resorptive cells, kind of touch that. They realize that's not mineralized surface. They're not supposed to be, attacking that surface. If that surface is somehow sloughed off, and you end up having inflammation, some of the factors involved in inflammation could potentially lead to these monocytes that come to the area to differentiate into these odontoclasts, and then latch onto that surface that's calcified, and then slowly burrow a hole and go inside. And that's how these things occur. It's a combination of these two main factors: the presence of inflammation and the denuding of the non-mineralized layer of cementum or inside the tooth. Internal root resorption is almost the same type of a mechanism as well. That's by the predentin inside the root that is going to denude it. So when this happens externally, and the difference between internal and external is that, on the internal resorption situation, once you end up having necrosis, now those cells are kind of dead and it doesn't continue. If only in those situations in which you have a chronic inflammation going on due to presence of decay or something that's happened up there that doesn't kill the nerve but still maintains the infection, you end up having these internal resorption processes. But as soon as the pulp dies, then that is arrested. But externally, because there's constant perfusion, these cells can continue and burrow a hole into the dentin, past the cementum and into the dentin, and then they spread. And what's interesting is they don't actually perforate completely through into the pulp, because, again, on the inside layer of the pulp, you have that dentin that has the predentin. So they tend to kind of circulate and go around the pulp, and they go up and down. And that's what creates the so-called classifications set forth by Dr. Hidesay, who's a professor at University of Adelaide in Australia, where he kind of set up these 4 classifications, one being just very incipient at the early stages of resorption taking place. The class 2 being a little bit, moving forward and being deeper into the dentin, but not yet into the pulp. And class 3 is going in close to the pulp and then moving up and down a little bit. And then class 4, which is the last one, and that usually is the most invasive one, is kind of continuously one or multiple sites of entry and going up and down and surrounding the pulp. So based on the level of resorption, and that's why time is an important factor, and how quickly do we determine these is an important factor. Then you are going to have a different prognosis. The studies that Dr. Hidesay did in this in his evaluation, he found that in class 1 and 2 cases, they managed to get about 100% success rate in terms of addressing these resorptive defects. In class 3, it dropped down to 78%. And in class 4, it was as low as 12% success rate. Now, the key here then is to find out how, as quickly as possible, that there is a resorptive process. And I personally myself have determined also that there is another second factor that's super important too, and that's surgical accessibility, which means that's the term I used to say, is the lesion at a location that you could then surgically access and repair? Now, what that means is that if the lesion is on the interproximal areas or antidistrication, then it's going to be surgically inaccessible, and it's very difficult. And the overall success rate drops down. But if it is just right on the buccal area, oftentimes those are easily surgically accessible, and the success rate is a little bit higher in those cases, and sometimes coronally on the lingual side. But that's the key factor. And the other problem that we have in the literature, Ash, is that we don't have long-term longitudinal studies to follow up these cases to see how long they actually last.
Yeah.
The recent article you're referring to were kind of indicating that as well, but this has been something that I've kind of been hollering about, is that, why are we going through all of these treatments without really having a basis of how long will these cases will last without any treatment? Because I've seen people just, oh, you have external root resorption, it's not surgically accessible, let's extract it and replace it with an implant. There's absolutely no reason for that. Unless there are symptoms present, then these things could linger on for years and years. And, seeing them be inside the mouth for 15 years even after is not a surprise. So the two main things, in my personal opinion, that we need to kind of pay attention to when you see and diagnose a case that you see that has external root resorption, is to determine two things. Number one, it's surgical accessibility, which you can find out with a CBCT by taking a three-dimensional image and find out, is it easily accessible by surgery through the buccal or the lingual aspect, or is it hidden mid-root down below the bone in the interproximal area, which will then involve removing a lot more bone to get to it. So that's the one factor you need to determine. And the second factor would be the rate of resorption. And that's kind of the key factor, because, when you look at an X-ray periapical or a bite wing or something that you see a patient that has a resorptive lesion, all you're seeing is a snapshot in time. So you need to kind of connect that to a historical X-ray. And if you don't have historical X-rays, then you'll have to not treat unless the surgical accessibility is really right there and it's easy to treat, until you have a sense of how fast is this thing growing. So I would certainly wait 6 months or a year if you don't have another X-ray to historically to compare to, in order to see how things are going before you jump into a big fancy treatment. So those are the main factors that I think are important. People have to pay attention to in order to be able to treat these patients with the kind of a best outcome scenario.
Regarding that, we see a lot of these, but I don't see a lot of them symptomatic. That's the most bizarre part of it, and I don't know if that's the same for you.
The reason they're not symptomatic is because what creates symptoms? What creates symptoms is inflammation, right? And is the type of inflammation that is generally associated with infection, because that's acute inflammation. Acute inflammation will cause more pain. If it's chronic inflammation, it doesn't. But these resorptive lesions themselves are not inflammatory. Remember, inflammation triggers them. But then after that, it's actually a natural process of bone resorption. The only problem is that it's occurring at a place where it's not supposed to be occurring. So in the absence of infection in those areas, these things would be completely asymptomatic until they get to a class 4 level where they really get close to the pulp, or if they start to become transcrestal or transgingival, which means that they start to impinge or go above the area of attachment, in which case now they're acting as a natural undercut underneath the tooth that could then potentially get food and become inflamed or infected and cause a periodontal abscess. So you end up, oftentimes in these teeth, you end up getting periodontal abscesses as opposed to endodontic infections. Mm-hmm. So that's a key point here to keep in mind, that the fact that you don't see any symptoms because these are sterile and they're merely just resorptive defects that are just removing dentin without really causing inflammation in the pulp, where you're going to get the symptoms. And where you get the symptoms is sometimes from a periodontal infection, where they end up causing a big hole into the tooth as it starts to traverse into the non-sterile supragingival area beyond the attachment. And now all of a sudden you can get food and all kinds of debris stuck in there that causes a secondary periodontal infection. And once you get that secondary periodontal infection, especially if they're deep, now they could cause an endodontic infection, and just as a continuation of the same process of microbial movement. So that's another key thing to keep in mind, is that you're not going to see these teeth have symptoms, and you have the luxury of waiting, especially in the absence of symptoms. So you should never really extract these teeth just because you see resorption, even if it's devastatingly large, unless it is a tooth that has severe strategic value, like a central incisor or something, where the patient's really concerned, but if it snaps off, how it's going to look, which in my opinion, if you can still get a few more years out of it, that still is better, even if it snaps off, because even if it snaps off, you can always just, as long as they keep that tooth, you can merely just do a kind of a Maryland bridge type of connection on a temporary basis on the crown portion of the tooth and keep it in place. So it's just one quick visit to the dentist, and then until you can figure out what you're going to do with the rest of the tooth. And there are many other options in this front as well when you see resorptive defects that are, especially in younger patients, that have the potentially resorptive defect, but they're not candidates for implants. You can always do many different things that have been already talked about in the literature by Malgren and other people in terms of root submergence. You could submerge the roots. You could either do the root canal or not do the root canal and just cut off the root and let the tissue cover over it, and then have the crown coronally fixated in the same type of a Maryland bridge, or find a different type of a provisional bridge until they get to the age where they can have the implant. And this way you can preserve the alveolar ridge without having to remove the root portion. So there are many options when it comes to this. You just have to kind of be aware of the big picture and make decisions based on that specific tooth and that specific root on that specific patient. So it's probably one of the best examples of customizing care for patients, where it's going to you have multiple different options in terms of more aggressive, less aggressive, with the idea of preserving the alveolar ridge to the extent possible and keeping the tooth for as long as possible. So again, going back to the two main factors that you need to determine is, number one, surgical accessibility, and number two is the rate of growth. Now, these are not in the literature. These are my own personal experiences. So, but let's consider this the publication right here.
Right. I think as a practitioner myself, the fear, and you answered already, but just to come back to it, the fear is, okay, we're going to decide not to do anything. Then the tooth becomes necrotic, or like you said, it becomes more of a periodontal issue, and then you get that bone loss. And I think in my own experience, it's kind of that fear. It's not a fear, but that the concern that, okay, I'm going to lose alveolus secondary to, say, that periodontal infection, which then maybe become an endodontic infection, and then we lose those cortical plates. And then, it's less of an option to then do an implant. But what I'm hearing is that it's just routine follow-up, definitely inform information for the patient, so they can keep track of coming in, and then you can catch it when it becomes that type of issue.
Well, I remember, I'm talking about the follow-up. Remember, number one factor is surgical accessibility, and number two is rate of growth, right? If surgical accessibility is there, you can easily access it, and it is a type 1 or type 2 lesion, you want to address that immediately, because that has the best success rate. And by addressing it, your goal is to surgically flap that. You don't need a root canal in those kinds of cases either, right? All you do is just surgically flap it back, and then repair the lesion by essentially with the goal of removing the resorptive cells. Yeah. The goal here is to remove those odontoclastic cells so that you can prevent them from further egress and growth inside the root, and then repair the hole with a material. And that material, if it's subgingival, it would have to be some type of a pure bioceramic. And if it is transgingival, then you probably would need to either think of some type of a modified glass ionomer or resin ionomer material. And another technique that I've kind of described also in lectures, I guess not in video, but it is the concept that even if you have a transcrestal lesion, if it's large, you always want to have a pure bioceramic where you're going to want to have attachment, because that's going to turn into oxyapatite, and then cementum can grow over it, and you're going to get real attachment to it. But if you put a resin ionomer, you're not really going to get an attachment to that. So a technique that I described was in some of these larger transcrestal lesions, fill the whole thing with a bioceramic so that a part of the bioceramic, I use BC putty, as you know, which I have developed, let it heal. And then once the tissue heals fully, then I would remove the portion of the bioceramic that is supracrustal or supragingival, if you will, that I can see, and then repair that. We could do even a bonded composite there, like a deep class 5 bonded composite, or with a resin ionomer at that point. But the goal is to make sure that you have that bioceramic where there is gingival attachment, because you're going to get attachment to that, but you're not going to get it to a resin material. Ash, basically what I'm talking about is, let's say, a common area where you see these types of problems. Let's say it's on a canine tooth. These teeth, these canines, actually take a side angle of it. They tend to, because of the fact that they're at the corner of the mouth, they tend to get a lot of these labial during these expansive forces in the orthodontic side. Is they end up getting a lot of trauma right here in the buccal area, and that's generally where they end up having a lot of the resorptive stuff take place. So they end up getting something like this. Now, if this resorption is actually below the gum, then you obviously, if this is what you have, and then your attachment is actually further up here, so you have a proper attachment, right? Then all you do is you just have to kind of fill this with a putty, and you'll be in good shape. You don't have to worry about that. That usually has a very good success rate, right? The problem is when the lesion is actually further up, and it's kind of coming all the way up to here. And now you kind of find out about this after the patient comes in with some type of a periodontal breakdown and bleeding upon probing, right? So in these types of cases, my recommendation is that you fill the whole thing up with the putty, and then you're going to end up getting some type of a healing, which is going to, obviously, you may have a little bit of recession here at the end. So you end up getting this type of a healing, right? And you'll see a little rim of the white bioceramic here.
Yeah.
And then what I want you to do is to just go in there and remove this part. And then fill that with your composite material of choice, or with a resin ionomer at that point. So you end up having 2 layers. You end up having a bioceramic layer where you have the attachment, and then you have a area that is better suited for the external environment of the saliva. So it has to have low solubility and more polishability. So you end up having something, it could be a pure composite, or it could be a resin modified glass ionomer, something of that sort. And that combination will give you, basically, it'll optimize each surface with what it would be best. Now, you may say, well, can we just do all that in one visit, right? Can we just kind of fill with the putty up to here, right? Let's just fill with the bioceramic up to here, and then the rest of it fill with the let's say the liner. It's very difficult. I've tried to do that. It's just difficult to manage it, because at that point the bioceramic is not set. It's still kind of floating, and then you end up not being able to get the most of it. Now, it's important also to realize that a lot of these companies nowadays are trying to put a little bit of resin in their bioceramic. Rather, it's more like putting a little bit of bioceramic in the resins, right? And so that they could get, they call it a light cure bioceramic, but it's not possible to have a light cure bioceramic and have a pure hydration precipitation reaction. So you end up still having that matrix of the resin kind of strangulate the bioceramic, so you don't really get the bioactivity out of it. And you're not going to have, the hydroxyapatite crystals form over that layer, because that's what you want. You want the hydroxyapatite crystals, like right this layer, like this area that you're going to be looking at when it's a pure bioceramic, that surface. So let's say like right here that you have filled, it's a bioceramic when you set it, but then afterwards the layer crystallizes over it, and that's a hydroxyapatite layer. So you essentially have hydroxyapatite root, and then hydroxyapatite. So the cementum from here will grow over it, and it will repopulate this area with cementum, which then allows the sharp fibers and so on to connect to it during a normal reattachment process that occurs every time, you're doing scaling of root planing and that kind of stuff. And, what I was talking about in terms of surgical accessibility is an important factor here, is to understand that, let's say here, if you have a couple of teeth next to each other, if your resorptive defect is here, that's fine. But if it's here in these areas,
yeah,
those are the ones where you're going to want to make sure you watch and monitor, because, in those kinds of cases, you always have to think that there's risk to no treatment, but there's also risk to treatment, because you can get things started and then all of a sudden the tooth can blow up and now you don't have any recourse. The patient ends up losing the tooth prematurely.
Yeah.
So you always want to make a treatment planning decision based on the fact that if the tooth is surgically accessible, you can always save it surgically if things go wrong. And that's the main component of things that people have to figure out. Number one, surgical accessibility. Number two is the rate of growth.
Dr. Nasseh, thank you so much again for your time. I'm super grateful for your time. You're a busy person, and to take the time to explain that in my own case and for everybody, whoever watches this, I am super grateful, and very grateful for your time.
It's just always a pleasure to be with you, and keep on doing what you're doing. You're doing a great job, and I love talking to people like you who are passionate about endo and love what they do. So hopefully we'll get together soon again.
All right. Thank you so much.
Cheers from your mug here. Thanks for sending me the.
Yeah.